Welcome to JBJS's Audiocast on proximal humerus fractures. My name is Chad Kruger, Deputy Editor of JBJS. Over the next 45 minutes, you will hear a webinar that was delivered live to over 1,000 orthopedic professionals. At the end of this audiocast, you are welcome to view the full webinar on the JBJS website. The webinar was co-moderated by Dr. Bill Mallon, Editor-in-Chief of the Journal of Shoulder and Elbow Surgery, and Dr. Andy Green, JBJS Deputy Editor. The incidence of proximal humerus fractures has been increasing while the indications of surgical and non-surgical treatment of these challenging fractures has evolved. Many questions remain regarding how to best manage these fractures secondary to individual patient characteristics and surgeon experience. Beyond the dilemma of operative versus non-operative management lie many decisions about technical details if surgical treatment is selected. You will hear from Drs. Mark Frankel and Dr. Brent Ponse, who will present their papers, each followed by commentaries by Drs. Joaquin Sanchez and Javier Geraldi. At the end of the discussion, you will also hear the questions and answer session between the speakers and attendees. We will now begin the audiocast with Dr. Frankel's presentation.
Good evening, everyone, and thank you, Andy and Bill, for moderating this excellent session. So initially, the purpose of my talk was based upon a premise I had. As orthopedic surgeons, we are often faced with two aspects of determining how effective we can be. One is the cognitive component, and the other one is the technical component, and we're reimbursed for both. The cognitive component often is undervalued, in my opinion, because there might be circumstances when it's quite difficult to consider what is the ideal treatment, hence the difficulty when you're uncertain of what treatment is best for that particular patient. So the attempt of our study was to try to uncover whether or not, in cases of uncertainty that did in fact affect outcome because of the technical difficulty in the cognitive process of making decisions on uncertainty. Furthermore, I felt that as we increased our knowledge, we would change our paradigm relatively quickly and thereby able to adapt to new knowledge that is uncovered. So we know that proximal humeral fractures are complicated because there is so much disagreement about fracture types and the various different treatments that are available. So this might be an example of a case that might be one that would be difficult to classify and might be then difficult to idealize, consider what ideal treatment you'd want to do for this particular patient. So we decided that in order to try to study this question, we are going to look at how, over a scope of about 15 years in our practice, how different factors would affect the treatment of proximal humerus fractures, such as the introduction of new technology, to report on the clinical outcomes of patients treated surgically for proximal humeral fractures, and to assess the effect of uncertainty in trying to elect what type of treatment would be idealized for each patient, with the hypothesis being that if there was a degree of uncertainty amongst orthopedic surgeons, that would impact outcome in a detrimental fashion because of the increased cognitive difficulty in determining what's ideal. So this is our design. We had, over this 10-year period, 476 patients that we treated operatively between my partner, Dr. Mark Mile, and myself over this time period. And we we separated them into either they were treated with open reduction or internal fixation, hemiarthroplasty, or reverse shoulder replacement. We then tried to determine how the influence of introduction of technology altered the way that we treated these patients over this period of time, because we had, during this time, the introduction of locking plates and reverse shoulder arthroplasty at various times. The second thing is we wanted to see about the effect of uncertainty in the decision-making process. And in order to do that, we created clinical vignettes of 250 of those patients that we treated operatively, and we threw in 24 additional patients that were treated non-operatively to try to identify these patients and then determine with 3 fellowship-trained orthopedic surgeons and 3 fellows how they would decide what treatment they would do based upon these vignettes, with the thought being that these would then be related to our ability to agree or disagree. And if there was a unanimous agreement of treatment, and then that's the treatment that we actually performed, such as in 89 of the open reduction internal fixation patients, we compare that to those patients in which we did not have unanimous agreement and had the similar type of treatment. So here's some examples. This is a 30-year-old male, right-handed, and he had a motorcycle accident, and you see this fracture. So in this case, we had unanimous agreement of all the surgeons of what we selected and what was actually done. Here's another example, 44-year-old female, fell off a horse. You can see the above injuries. Again, unanimous agreement by all the treating surgeons, and that was actually what was performed. So here's an example, a 64-year-old female, or male, excuse me, and you can see the, again, injury films. And in this case, there was disagreement. There were some of the surgeons that selected open reduction, some with reverse, and the actual treatment was a reverse. So that would be an example of a disagreement. And here's another example. Again, you can see a 68-year-old female. Again, there was disagreement with actual treatment, which was over IF. So now when we looked at our results, we can see that the introduction of technology occurring when locking plates were introduced around 2002, you can see the shift in terms of the number of fractures that were fixed. And you can see that both in the graphic and the line bars. You can see a substantial increase of open reduction internal fixation after locking plates was introduced. And similarly, you can see that there was a slight increase, on the reverse patients. One reverse fracture stem was introduced around 2011. So that then demonstrated that, in fact, introduction of new technology did, in fact, alter our treatments. When we talked about the agreement, when we looked at when we had unanimous agreement, there was about 70% of the cases. And this was substantially improved compared to our fellows. So when we had less experienced surgeons, they had less agreement than we had experienced surgeons. When we looked at the patients that actually had the procedure done, like an open reduction or fixation where we had agreement, compared to those where we had open reduction or internal fixation where it was not unanimous agreement, there was a substantial improvement in those patients in which there was unanimous improvement, providing evidence to suggest that when it's easy to figure out what we should do in terms of the treatment, we all agree, it's likely to end up with a better outcome, providing some evidence that the technical portion is one aspect, but the cognitive decision-making process also plays a role in the outcome of these patients. So in conclusion, experienced surgeons tend to have a better agreement in determining what type of treatment would be performed for proximal humerus fractures compared to less experienced surgeons. However, there is still a fair amount of disagreement, suggesting that there will always be some uncertainty because of the complexity of trying to make assessments of these injuries. When we do agree, and it's more obvious about what the ideal treatment is, that component then is easier and therefore leads to predictably better outcomes. And again, it just sort of reminds us that in those circumstances, when you're in the room with the patient, and you're not really sure whether or not you should operate or not, and then what type of surgery you should do, that's a sign that that probably is a cognitive difficulty issue. And you might try to phone a friend or get some additional way to try to consider how to best manage that patient. But even in those circumstances, it probably will add a degree of difficulty in managing these patients, and hence probably an effective outcome. And finally, the technology advances do influence our decision, showing that when locking plates were introduced, we tended to use them more, and the same thing with the introduction of reverse shoulder replacement. I thank you for your attention.
Thank you, Dr. Frankel. Now let's hear from Dr. Geraldi.
Thank you, Andy and Bill, and thank you, Mark, for that great presentation and that interesting paper. So in this study, it was a retrospective review of decision-making in the management of proximal humerus fractures. And the authors and the surgeons involved had to make decisions regarding management of these fractures, but the available hardware for the management changed during the course of the study, so that the options that were originally available to certain patients that were not available were now considered. And so these two tended to be the locking plate for proximal humerus fractures and the reverse stem, which became available later in the course of the study. So in cases which were unanimous in agreement for ORIF did better. So the underlying question here is, why is that? So what factors led to unanimous decision by the panel? And the answer is that probably that particular hardware was more ideally suited for that fracture. So in cases in which the surgeons looked at it and said, oh, I know that a locking plate can treat that well, they agreed unanimously, and that fracture was more ideal for that treatment modality. And in other cases in which they looked at it and thought perhaps that fracture was not well suited for a plate, the results were not as good. So the original decision making in this study was based on the best option available, but that doesn't necessarily mean that it was the ideal option for that particular patient. And so if you see this fracture on the slide here, there's a 26-year-old cyclist, and you could imagine that multiple surgeons would come up with different treatment options for this fracture, because there really is no ideal treatment right now for this type of fracture in a young patient. We actually treated this patient with open reduction internal fixation. He did well, waiting for AVN, but it hasn't happened yet. So locking plate and reverse total shoulder have answered many problems in the management of proximal humerus fracture, but they haven't answered them all. And so what problems did they address? Well, the locking plate improved fixation in the proximal fragment. That was a big problem with more conventional plates in which solid fixation could not be obtained there. And it also improved fixation of the greater tuberosity and resistance to varus displacement. So in cases in which this was a problem with previous types of hardware, the locking plate did a good job of managing that. And what problems did the reverse prosthesis address? Primarily greater tuberosity pull-off. And so Dr. Frankel has done research regarding fixation techniques for the tuberosities, and we would go through putting in multiple sutures in tuberosity to try and obtain fixation in a humeral head replacement. And despite that, we'd see significant amounts of cases of greater tuberosity pull-off and then unreliable function. And I can tell you that in my own practice, even though I'm the same surgeon I was several years ago, I can get very reliable healing of the tuberosities now on a reverse prosthesis that I couldn't get. And this has changed my attack on these type of fractures. I would do anything to avoid a humeral head replacement over the last several years, and was using a locking plate on many cases, which now I would use a reverse prosthesis. So we have ongoing challenges. As Dr. Frankel said, we still can't agree on reliable fracture classification, and it's difficult to discuss these cases if we can't even agree on what it is that we're treating. And the other issue with both of these new types of hardware is that they don't do the operation for you. And it's very tempting to say, well, I'll go in there and put the plate on it and I'm done. And as you'll see from Dr. Ponse's discussion later, that medial calcar comminution can be a problem. Reduction techniques have to be performed in order to gain stable alignment of the fractures before you put the plate. And you still have to be very careful in terms of your placement of your reverse prosthesis in terms of height, inversion, and fixation of the tuberosity. So this still requires a significant amount of technical expertise in these fractures, despite the new available hardware. One common issue with calcar comminution is augmenting the locking plate, often using intramedullary grafts, such as seen in this case. And this patient presented with post-traumatic arthritis, and now this is a real dilemma in the management of fracture sequelae, because the intramedullary canal is now filled, and that has to be addressed at the time of revision arthroplasty in these cases. Severely comminuted fractures in young patients continue to be a problem, and we use open reduction internal fixation trying to avoid a prosthesis currently, but is that the right answer? I think you get a significant amount of disagreement in the cases such as that. I think it's also important to understand and remember that these advances in technology have not only improved our management of the initial fracture, but also of sequelae of fractures. So that now with short stems and stemless prosthesis, we can deal with post-traumatic arthrosis much more effectively, even in the face of a clogged canal or a deformed humeral shaft that gave us problems before with the standard longer stems. And in cases such as this that presented with an infected shoulder following open reduction internal fixation, we were able to treat him sequentially with placement of a spacer and followed by a reverse prosthesis. And even despite the fact that his greater tuberosity was displaced, he had reasonable function, and this type of result was not possible before that technology was available for us. So in conclusion, better treatment results are seen in cases of unanimous decision because that type of treatment is probably closer to the ideal for that particular fracture. Fractures without ideal hardware solutions continue to exist, and newer hardware solutions, as they become available, surgeons' choices will continue to evolve towards a more ideal solution. Improved options for treatment of fracture sequelae will have an impact on our treatment of the initial fracture as well. Thank you.
Javier and Mark, those are great presentations, and I have a couple questions. We have a couple minutes here. Javier, first, you have a lot of experience with proximal humerus fracture, fixation, and replacement. And can you tell us what are the factors that you use to consider in making the decision between conservative open reduction internal fixation, hemiarthroplasty sounds like it's not an option as much anymore, or reverse arthroplasty? What are the factors that you really consider when you sit down with an individual patient?
So there's a lot of factors, and I think you have to talk yourself into surgery because we know that the majority of these cases can be handled non-operatively. And so certainly age of the patient and functional demands plays a significant role. And then in certain displacements, you make decisions. So a greater tuberosity, typically 5 millimeters, is what's acceptable of displacement. In terms of angulation of the surgical neck of the humerus, that angulation will equate almost directly to the loss of forward elevation. So it depends on how much forward elevation the patient can lose. Factors such as that guide me. And in general, the older the patient, the more I'm willing to try a conservative treatment course initially and avoid surgery. And especially now, since we can treat the fracture sequelae so much better, it gives us a little bit of a safety valve in terms of if we make a mistake and the patient does poorly, we still have a lot of good options, especially in the elderly patient, for the management of the sequelae with the reverse prosthesis.
Mark, you're really one of the pioneers of reverse shoulder arthroplasty. And given your years of experience, you've been through this whole evolution. Do you think there's any indication at this point for hemiarthroplasty for fracture? And if you do, what are they?
Yeah, you know, Andy, it's pretty uncommon for me to think that I would use a hemiarthroplasty to treat a proximal humerus fracture. I haven't done that for many years, although perhaps a young patient with a head split or a very young patient in which I thought that there was good tuberosity that would allow me to get a secure reattachment of them anatomically and reconstruct the head segment anatomically because the head segment was not amenable to ORIF. That would probably be a case, but I have not done that operation probably in about 5 or 10 years, I'd imagine.
So I think let's move on and have Dr. Ponse present his study and his presentation. Brett, are you there?
Absolutely. Thank you, Xavier and Mark, Andy and Bill. Appreciate the opportunity to share our work. 2 things I want you all to take home from this presentation is that treating these fractures are extremely difficult. So rest assured, we're all in this together. The second is I want to go over the presentation to create one singular argument of the support of the importance of the calcar when fixing these fractures. A little bit of background, fairly common, 4 to 5% of all fractures, and yet nearly half of all humerus fractures, and that these are relatively common in the elderly population. and is also expected to have a significant increase over the next 3 decades. How about the perspective from the international look? In Finland, we had a significant growth, and this has particularly happened since fracture plating with locked fixation in 2002. In the U.S., now we see the picture of that growth visually. How about in the U.S.? Well, looking at the database from the state of New York, over the age of 65, this incidence of these proximal humerus fractures increased 28%, and yet operative management increased greater than 40%. And with operative management with open reduction internal fixation, primarily with lock plating, went from 47 to 59%. So when we look at the treatment options that we have available today in the armamentarium, the TRIOPS, we have nail, hemiarthroplasty, closed reduction, percutaneous pinning, but the real ones that we have at our disposal today, primarily reverse, and what we're going to be focusing on is open reduction internal fixation. So let's talk about the deforming forces that dictates the fracture personality. The rotator cuff complex, which we see in red, abducts the metaphyseal segments. And then with the latissimus and the pectoralis major, it has an adduction force on the diaphyseal fragment, and that's the green arrow. And what this results in is a varus cantilever force with the fulcrum in the calcar or the medial column region. And with inadequate calcar support, varus collapse occurs. And with this, more important than implant selection is the ability to achieve stable reduction with calcar support. Now, once again, going back to that first point, that these fractures are challenging to treat. These have a very high complication rate, and yet the complication rate is influenced by experience. So I hope today we can take away some pearls. Some of these complications you'll see as follows, but when we talk about one of the most important and common is varus displacement. And when we talk about this, is also exponentially increasing in older patients with osteoporosis, which are the ones that generally have these fractures. And why is this? It's due to the common lack of cortical support as a result of comminution of the medial calcar. So let's take a look at the literature to see that the weak link is at the calcar. And when we're told with locked plating that all screws are equal, well, that's true where the screws interface with the plate, but not where the screws head to. So in a sense, not all screws are equal when it comes to locked plating. Let's take a look at the literature. Where's the best bone? The maximum bone quality is in the inferior aspect, and so surgical stabilization techniques should use the inferior medial trabecular network to increase mechanical quality of the fixation. The inferior medial region, in another paper from Gardner, talks about if support cannot be done anatomically with cortical contact, it may be achieved with purposeful inferior medial humeral head screws, that is, screws along the calcar. And this is demonstrated in this picture in which you see that calcar screw, that kickstand screw, is superimposed. That screw is not really there, but they proposed that possibly if we had that kickstand screw, that we could have prevented the varus displacement and the collapse along with the screw penetration. This led to our study in 2013 in which we looked at two things. One is going to be the importance of calcar screws along with the importance of comminution or anatomic reduction. So we had 11 pairs of humerus. 6 of them we went and made them comminution. So you see the first 2 pictures and how there's a gap along the medial calcar. And the second 2, these are non-comminuted fractures, but you'll see in each set you have a short screw and a long screw. That is, whether or not the calcar has been restored or not. So the results of our load to failure analysis is that the medial comminution specimens with the longer calcar screws had 49%, the medial comminution specimens had 49% less load to failure values than the non-comminuted specimens. And that when we used longer screws across the calcar, that resulted in 200 newtons higher load of failure than the short screws. So you see the 2 columns on the left are the comminution, notably lower values for load to failure, versus the non-comminuted short and long screws, calcar versus no calcar fixation. Carrying on, what do we see in the literature? It's replete. Over and over, we're going to see obtaining medial support is an important factor in presenting major bone and fracture-related postoperative complications such as loss of reduction or non-union. Based on our results, another paper, strong medial support should be reconstructed in every case. Another paper, use of inferior medial screw running through the varus curvature of the surgical neck prevents varus deformity, improves functional outcomes after surgical treatment of proximal humerus fractures. Anterior inferior screw provide medial column support for fracture healing. So the literature is pretty clear once you start teasing these points out. And we think about the complications, whether it's screw penetration, well, often that's going to be because the screws aren't moving, but the fracture is moving around it because of varus displacement. This paper talks about through the placement of screws in the inferior medial aspect of the humeral head, it counteracts the varus deforming forces acting on the head fragment, and therefore reduces the risk of secondary loss of reduction and varus collapse. So let's take a step back and look at the risk factors for loss of reduction. I can't control osteoporosis. The patients come to us. I can't control a fracture that is already in varus displacement, like you'll see in the upper left. Medial comminution, I can't control that. But the one thing I have at my disposal is either to get an anatomic reduction or to support the medial column or the calcar with screw fixation. And what's interesting is so often we'll see the second picture on the left, you'll see people going to a longer plate thinking that it's a shaft issue. It's not, it's a head issue. And what the real problem is proximal not supporting the head, which then ultimately leads to the fracture returning to its original varus position and then leading to a poor outcome resulting in the need for an arthroplasty. So in short, all screws are important when we talk about locked plating, but the calcar screws are most important. To review, proximal humerus fractures, the treatment of this with locked plating is one option for these complex fractures. Despite biomechanical advantages of locked plating, the humeral head remains the weak link, and that support in the medial column or the calcar region is critically important in providing construct stability. Thank you.
Thank you, Brent. Now let's hear from Joaquin Sanchez.
Thank you very much. Good night, everyone. What a great webinar. Congratulations to Dr. Frankel and Dr. Ponse, two great publications, and thank you also to Andy and to Bill and JBJS and JSCS. So I think Dr. Ponse's presentation is a great introduction to what we, I think, all realize as being the scope of the problem. So even though we're all enticed by the potential value of lock-in-place fixation, the reality is that if you look at the reported literature, the failure rates are just too high. So the question is, can we get better when we choose to perform open reduction and internal fixation? And if you look at patients that have failures and you wonder why did this fracture fixation fail, oftentimes there is one of three elements that are involved. Either the surgeon didn't get the right reduction, or the reduction was correct, but the surgeon didn't get enough stability. Or finally, some patients will have compromised healing because the fracture pattern will compromise vascularity or the host is just poor. And of these three, there are two that we can control, as Dr. Ponse just mentioned. One is to get the reduction right, and the second, to obtain adequate stability. But it's important to realize that how you get your reduction and how you get your stability is very different depending on the fracture patterns. So in my practice, I have come to realize that of the many fractures I take to the operating room, there is two particular patterns that are extremely different. One is what I would call a varus posteromedial fracture. This is a CT scan of a patient with such pattern. And as you can see on the CT scan, there is comminution in the posteromedial junction between the humeral head and the neck. That's why the head is into varus and flexion and some retroversion. In this pattern, as you can see in the animation, what happens is that as the load impacts the proximal humerus, there is a three-dimensional rotation of the humeral head, and there may be or not associated fractures of the greater or lesser tuberosity. This is completely different than the valgus fracture, where, as you can see, the head is displaced in the complete opposite direction. So here, the head is going to be displaced into forced valgus, and it basically will explode the tuberosities. And again, you can see in this animation How as the head displaces laterally or into valgus is going to, most of the times, displace or explode the tuberosities. So that has very important implications for fracture reduction. If you want to get your reduction right, you actually have to do it differently depending on the fracture pattern. In both of them, sutures through the calf will help you, will be your friends, because with those sutures you can control the fragments that are attached to the rotator cuff. In the varus pattern, which is the one that Dr. Ponse analyzed with his study, use of elevators or impactors are, in the valgus fracture, use of elevators or impactors will help you get the head out of valgus. But in the varus posteromedial fracture, it is very difficult sometimes to get the head out of varus, and I find it useful to place K-wires in a very steep angle and then use them as joysticks to get the reduction right. So the key is, what can we do in 2018 to improve fracture stability? And I think the number one is to obtain bone contact. If there is no comminution, it's very straightforward, and anatomic reduction in a fracture with no comminution will provide bone contact. But if there is comminution, you have to find a way to improve your bone contact, and you can do that by either shortening and impacting the fracture to some extent or adding bone grafting. The second is to support the humeral head, and it's very interesting to realize that the tuberosities, when they're properly reduced, will support the humeral head, and of course you can also add bone graft to support the head. The screws are extremely important, and this is the value of the paper of Dr. Ponse, where he emphasized the very important value of the calcareous screws. So it's important to remember that screw penetration can be a problem, so as you place your screws, you have to make sure you prevent that. And in Europe, there is increasing good experience with use of cement augmentation at the very tip of the screws. And finally, you can augment your fixation using sutures to the calf of the plate. This is a graph from Dr. Ponce's paper we just analyzed, and pay attention to the fact that even though it's true that in the fractures with comminution, adding long screws increased the load to failure from 500 to 635, fractures with no comminution had 980. So that has to tell you that it's very important to obtain contact of your bone in addition to using calcareous screws. So these are a few tips and tricks that I use in the operating room. I think it's important to obtain x-rays before you actually tackle the fracture, obtain your exposure, and the first step that I think we all agree upon when we're doing internal fixation is to place a few sutures to the rotator cuff, because they're going to help you, number one, control the fragments. So in this case, we're using sutures to the posterior cuff to control the gradient tuberosity, but it will also be helpful later on to provide fixation augmentation with sutures through the cuff and the plate. And then it's important to support the head. So number one, if you have some posteromedial comminution, you can consider shortening a little bit. Number two, bone graft is extremely important. So this particular example is a valgus fracture, so we're going to use impacted graft to elevate and support the head. It's very important also to realize that screw penetration can, for the most part, be avoided if you don't create a channel with a drill. So my preference is to drill only 5 millimeters, only the lateral cortex, and then use a depth gauge to get the length, and use somewhat shorter screws. The proximal humerus is not the proximal femur, and longer screws can really facilitate penetration. Finally, getting the screws under fluoro in the calcar region to support against posteromedial comminution and displacement, and augmenting the fixation through the rotator cuff will hopefully lead to a good outcome in your patients. And as I mentioned before, two ways you can use to augment your fixation further if you have to is to either shorten just a little bit, as in the example on your left, or potentially, if you use cannulated screws, inject a very small amount of bone cement through the screws so that they will increase the purchase of the screw thread into the humeral head. And luckily, most patients that do get a good reduction and fixation can do extremely well after ORIF. So I think the key message of this presentation is to remember that if you want to optimize fracture stability, you have to understand that there is two very different fracture patterns, the valgus posteromedial and the valgus fracture. Bone contact is paramount, and you can achieve it in the presence of comminution with either shortening and impaction or bone grafting. Supporting the humeral head is very important too. Tuberosities will help you, bone graft will help you, and the screws are critical, and especially those calcareous screws that are the topics of tonight's presentation. And then use sutures to the calf to augment your fixation. Thank you very much.
Well, Joaquin, that was outstanding. Thank you very much. Before we go to the question and answers from our participants, I have a couple questions for you and Brent. Brent, first, I want you to comment on some of the recent literature that suggests that maybe non-operative treatment is just as good as operative treatment for displaced proximal humerus fractures. In particular, there's the Proffer study from the United Kingdom that just recently had their 5-year follow-up published in the Bone and Joint Journal. What are your thoughts on that?
I would normally just be really quiet because I'm a surgeon and I like to operate, but that's a good question because it raises a really an important point of if the results are as good non-operative as operative, the question is, should we operate on any of these? And there's a couple questions that need to be addressed because a lot of the questions that we have really comes down to definitions. The proximal humerus, the 2 parts, the 3 parts, the 4 parts that Dr. Neer described, it's not universally described one surgeon to the next, so the inter-observer and inter-observer reliability is quite poor. It also raises the question as whether or not a population over in the UK is equivalent to a population, whether it's in Minnesota or Atlanta or down in Florida or even Alabama. I think the other part of it is the whole idea of equipoise, of being able to say this fracture I know needs surgery because in my experience it just won't do as well. So it raises a lot of questions and a lot of these good questions whether or not we do need to be treating them. But where we are in 2018, when we have in our armamentarium not only locked plating, and that was the majority of those fractures that were treated. And looking at that publication, of the 125 that were slated to go into the surgical fixation group, only 109 of them actually wound up having surgery. And of those 109, 90 of them had open reduction internal fixation. The next largest group was hemiarthroplasty. Only 4 of them had nails, despite being biomechanically and biologically superior. And then 4 had a treatment that wasn't described at all. So in thinking about what we're going to do, there's so much variety of what one surgeon does versus another surgeon, not only with the surgical treatment, but also with calling to these fractures, what is surgical, what's not, and how you describe them. It makes it for a difficult study. We recently just finished looking at the top 50 articles that have been cited for proximal humerus fractures. Only 3 of them are prospective randomized studies. And so the Proffer study, while it has problems, it needs to be lauded that it's only one of very few studies that are out there that actually look at this topic. And I think that really just draws on the need for us to be critical and to continue with good outcomes and good research.
Hey, Andy, I'd like to, this is Mark Frankel here. I'd like to chime in here for a second, if I may. You know, one of the issues about the Proffer study is they excluded those people that were obvious for those that needed surgery. So there's a group of patients they didn't allow to be randomized because they thought it was obvious they needed to have fracture fixation. And one of the purposes of our study was to try to address that aspect of selection. That makes it very difficult when you try to do a randomized prospective study because you can set criteria about who gets randomized to what, but there's going to be a number of patients in which you might not be certain on which ideal treatment is going to be best for that patient. And that uncertainty has real implications about outcome, and I don't think you can control for that in a randomized prospective study because that aspect of surgical decision-making does not really lend itself for that methodology.
The other thing that I think is important, this is Dr. Sanchez from Mayo, is that the reason why in these studies we do not prove that surgery is better is not because patients that are treated non-surgically do well. It's because we have such a high complication rate with internal fixation that the outcome of RIF is poor. So when you have a technique that has a 35% complication rate, including screw penetration, varus displacement, and so on, it's really difficult to prove that clinically you are better than no surgery. But no surgery doesn't leave most patients with a functional shoulder.
Joaquin, I just wanted to ask you, now that we've talked about how to use locked plates, how to optimize the outcomes or fixation, has the advent of locked plates actually changed your indications for surgery?
No, not really. I mean, if you think about it, and the locking plates were released in the market 17 years ago approximately, so it's nothing new. You know, I think what I have modified in my practice is how I use them more than changing my indications for use. fixation. But I think, like Dr. Ponse mentioned, doing a very good fixation of a complex fracture is extremely difficult, I think. And one of the issues that I have had, particularly with placing the fibula in the canal, as we all have mentioned, I think, in different venues, is that if you ever have to revise that patient to an arthroplasty, the canal can be very difficult to recreate. So something I've been doing over the last 2 or 3 years, if I have to support the calcar and the screws may not be enough, is to use a unicortical strut medial to the medial cortex, so it's actually extramedullary, but you can use it to lift the medial aspect of the head and get it out of varus. So I think that may be a better technique than using the graft in the canal. Use it extramedullary, only one cortex supporting the medial aspect of the head.
Andy, this is Javier Geraldi.
I was going to ask you the same question because you're a little bit older than Joaquin, and the plates weren't around when you started.
Yeah, well, the direct answer to your question is that it really hasn't changed a patient who would have treated non-operatively and turned him into an operative patient. So those criteria have still been pretty much the same, but it has influenced the selection process for me. And, when I was coming up, I trained with Ender's nails, and so it was very tricky to get those things in the right spot. And there's a lot of suture technique that was required and bone grafting to try and get the fracture reduced and stabilized. And in some ways, I think that that's helped me because I think that too many people use a locking plate like they use suture anchors in a rotator cuff repair and think that that one device does the operation for you. And as Joaquin pointed out very well, you have to reduce a fracture and know the maneuvers to do that. You have to find stability in some way and, stabilize that medial calcar either with bone graft or impaction or something, and do a lot of maneuvers before you apply the plate. And then the plate is your fixation device, but if you depend on that 100% for your fixation, you're going to have the high failure rate that we've been talking about. One of the things that we found in our series is that the soft tissue envelope is often intact in these patients, and you can use cancellous bone graft very effectively. You don't really need a structural graft in many cases. And so that if you pack cancellous graft in underneath the humeral head and then suture the tuberosities to each other, it creates an envelope of tissue that really supports that humeral head well. And that facilitates the revision surgery because you don't have a big chunk of fibular strut graft in there. And I think that really does complicate revision surgery for sequelae. And if you can avoid it, I would agree with that. And some of the other maneuvers that, we use variations on a theme of some of the issues that Dr. Sanchez talked about. And I use the plate as the joystick. So I will, in a varus impacted fracture, or in varus angulated fracture, we'll tend to put the plate onto the proximal fragment and then use that as a joystick to reduce it because those are very difficult to reduce otherwise. But I think that's the key thing is to get your stability from other factors and then use the plate as your last step. But don't depend on the plate to do everything for you.
So I'm going to turn to some of the audience questions. And I think we'll address this first to Brent, and the others can chime in. But what is your preferred approach, deltopectoral or deltoid splitting, and why?
That's a really good question because I also find that that's also quite regional. What part of the country, what part of the world you're coming from. Majority of these minimally invasive techniques that we're seeing, whether it's the deltoid splitting, are going to be from Europe or over in Asia. My personal preference when I'm doing a plate is the deltopectoral approach. At the same time, I need to make a confession here. I've been doing a lot more nailing as of late, and that's going to be more of a superior approach. So it really depends on what the fractures give me. Another point I'd like to make here is if it is an isolated greater tuberosity fracture, just a deltoid split is perfect because then you're able to see it, you're able to get an ideal reduction. But then it's sometimes difficult to get fixation because there's no real great singular plate that you'd have to worry about not engaging the axillary nerve if you have too long of a plate going from the deltoid split approach.
Andy, this is Javier Geraldi. I think one of the questions you ask yourself in these situations is why would someone want to do a deltoid splitting approach for this fracture? And the main answer, I think, is that it's they're having difficulty in placing the plate lateral to the bicipital groove where you want it. And so if you look back at one of the points that Dr. Sanchez made about use of sutures to fix your, to control your tuberosities, I think that's extremely helpful. So if you put those sutures through your rotator cuff posteriorly and then have your assistant across the table pull on it so you get an internal rotation force, it's very simple to apply a plate lateral to the bicipital groove from the delta pectoral interval. So I think if you can find a way to manipulate that proximal fragment with your sutures, you won't struggle to get that plate lateral to the biceps, and there's no reason to do a deltoid split and have a risk of injuring that axillary nerve. So I strongly recommend the delta pectoral interval for these approaches.
Hey, Mark, I have a question for you from the audience here, and I'm going to sort of combine two questions. One is, should CAT scans be routinely ordered or obtained in the assessment of proximal humerus fractures? And do you ever get into the operating room and change your mind? Or
Sure. So, I sometimes will get CT scans, but I'm always a little bit concerned that these patients are very painful, and laying down for a CAT scan is not something that I take on lightly, as opposed for my elective arthroplasty cases where I almost always get a CAT scan. So I don't always get a CAT scan. I tend to look at the plain films. They tend to guide me. Again, if I have some question, I might get that. And then the second question is, intraoperatively, there are times where I am unable to get the reduction, or the quality of the bone is so poor that I do occasionally make the change, but it's not very frequent. And I sort of try to time myself, because I find that sometimes I get confirmation bias. I'm going down this pathway because in my mind I'm going to fix the fracture, and I spend all this time, and it's that sunk cost fallacy where now I'm all in. So I try to time myself. If I might say, all right, I'm going to give myself 45 minutes to reduce the fracture. If I can't do it within then, I need to move on and make another decision.
Joaquin, anytime you ever get in there and change your mind, find something that you don't expect?
Yeah, I try not to because I like to be prepared, but there is times where I have tried to fix a fracture and I have been unable to do so, and then I have converted to an arthroplasty. And for me, the indication for a CT scan is mostly in those fractures that I'm going to treat with ORIF. So if I see a patient that has a minimally displaced fracture, or the patient has such an age or comorbidities that I would never operate on that patient, I don't see the value of the CT. If I already decided it is non-op, then I don't get a CT scan. And then on the other end of the spectrum, if I know I'm going to do a reverse, I don't get a CT scan either, because the glenoid is typically normal, and once you get the head out of the way, you can really assess the tuberosities. But if I'm going to do plate fixation or a nail, a CT scan really helps me.
So here's an interesting question that deals with problems afterward. So you get a good ORIF with a locking plate, and then the patient comes back at about 6 weeks, and there's been varus displacement. What do you do at that point? Joaquin, why don't you tackle that one first?
It depends on how much. So if it has lost, let's say, 10 to 15 degrees, and to the point that now there is bone contact, I may watch it, but I will watch it carefully, because the next thing that can happen is a screw penetration with the glenoid. So those patients need to be followed very carefully. If it's a massive redisplacement, I think you are forced to reoperate on the patient. And in those cases, I would really be ready to switch to an arthroplasty intra-op, because you may find that the second time around, the bone in the head is so poor that you just cannot fix it.
Andy, this is Brent. I'd like to
go ahead.
Chime in on this. I think 2 points to make up is, one is to relatively see these patients soon and to get radiographs early, just so you can confirm that you don't have that varus displacement, because if you are going to do something, you need to address it early, because once you start getting close to 6 weeks, it's pretty much going to be concrete, and it's going to be really difficult to do anything. The second part is, when I do see these patients, if they do have the greater tuberosity displaced, one thing that's a little bit different is I like to put these patients in a neutral immobilizer, which is really a 15-degree external rotation immobilizer, to help take some of the tension off the greater tuberosity. Otherwise, if you have your simple, your straightforward smart sling with a small abduction pillow, their hand's going to wind up being on their belly, and that's going to put greater tension on your greater tuberosity and greater tension on your repair, possibly increasing the likelihood for failure.
I would add on to that as well, Andy, that I think that, you know, at 6 weeks, to reoperate at 6 weeks, there has to be a very, very strong reason, because as Brent said, the soft tissue envelope is really quite bad. So if I see someone who I think is failing, I'll let them know that. I'll say, I think it's best to let your soft tissues settle down and wait till about 3 months. But, you know, you can usually tell on exam about how the soft tissue envelope is. If it's very stiff, and then it's going to be a very difficult surgery, not likely to end well. Whereas if it's softness around the incision, then you probably have a better chance of getting a successful revision.
I have a question I'd like everyone to comment, and that is, do you still use the NEAR classification? If you do or don't, how do you like to describe fractures or think about them?
So this is Javier.
Go ahead, Javier. Okay.
So I still use it. I mean, I still find it very helpful. And, you know, in the case I get a CT scan, those can help as well in terms of helping the classification. And I think, you know, what we need to be looking at is the other factors I look at is what is the chance of avascular necrosis. So I look at calcar displacement a lot as well. And I don't think that's something that was necessarily discussed a lot in the NEAR classification, but I'd look for predictors of avascular necrosis in addition to the NEAR classification.
So Andy, this is Brent. I agree with Xavier, but at the same time, I also like the idea of what Hurdle has done in more using the anatomic classification and just try describing where is the fracture line. Is the lesser off? Is the greater off? Is it the neck? And then with that, like he said, looking at the predictors for avascular necrosis, and Hurdle talks about size of the metaphysis calcar fragment and displacement along the calcar are both predictors of avascular necrosis. The shorter the metaphyseal flare is on the medial side, and the more displacement you have along the calcar.
So I'm going to ask you about that, but I'll have Mark answer. Mark, Ralph Hurdle's study looked at vascularity, but in the follow-up, it wasn't so clear that impaired vascularity led to avascular necrosis.
Yeah, you know, my sense is that...
Do you try to predict it? Yeah.
No, I don't think AVN, I think if you get an anatomical reconstruction, then AVN is a very dealable problem for patients. So early on, I thought a lot about the likelihood of AVN based upon fracture type as NEAR described it. Now I don't think that way. I think, is this a fracture that is substantially displaced, meaning that I think that it is going to not do well if treated non-operatively, and is the host able to tolerate it? So that's sort of, I don't really use a straight NEAR. I say, is it really displaced or not? And then I try to go by different fracture characteristics. So I don't use the AVN. I look at, can I reduce the fracture? Can I fix the fracture? And if not, then is it displaced enough that it needs to be treated with an arthroplasty?
So I'll ask one more question, and that is, you know, reverse shoulder arthroplasty seems to be much more predictable in our hands than hemiarthroplasty was. But we have some concerns about longevity. Is there an age cutoff or activity level at which you would not do a reverse arthroplasty in a complex fracture, or an age that you would automatically go to reverse?
For me, there's no age cutoff in which I think, because it's more fracture characteristics and patient characteristics, so age isn't necessarily the factor. There are things that probably make me less eager to do a reverse. If there's a high energy injury, I think those patients probably don't do well with anything. And by doing a reverse and them not doing well is worse than doing something else.
Joaquin, any thoughts on that question?
Yeah, I agree with Dr. Frankel. For me, it's more about the fracture pattern. So if I have a younger patient, but the fracture is really bad and I think a reverse is better, I don't blink an eye and I would do it. It so happens, though, that most of the fractures that are ideal for reverse do happen in older patients with osteopenia, so that helps a little bit. But if I have a patient that is 50 or 55 and has a really bad fracture, I would do a reverse if I think that's the best for the fracture.
Well, this has been fantastic. We could go for hours. I think it's a very common problem and very controversial.
That concludes this audiocast. If you would like to watch the full webinar broadcast, please visit the JBJS YouTube channel on JBJS Media. We hope you have enjoyed this audiocast.